So probably there's a number of people that know a lot about severe aplastic anemia, but I will give a brief background of that and MDS. So it is a very rare stem cell disorder in which the stem cells are damaged and are reduced or absent. And the reported incidence in North America and Europe is about 2 cases per million per year. So somewhere around 8 to 10 cases in British Columbia per year. It's about 3 times as common in Asia. There's no gender predominance. There's just as many males as females, but there does seem to be this biphasic pattern of distribution, meaning that it's something that you see, it's something that you see in teens or young adults, and then you don't see it very much until older patients. And I'm getting very close to that, so I'm not going to call that elderly anymore. Congenital severe aplastic anemia is very rare. You can see it. The most common forms that I see are Fanconi anemia and dyskeratosis congenita. What we usually see is acquired aplastic anemia, and while typically over 90% of the cases we cannot identify what causes it, the known causative agents are drugs, chemicals, radiation, and viruses. The presentation is pancytopenia, and for those of you who aren't familiar with that term, that means all of the blood cells are down, white cells, red cells, and platelets. And when you do a bone marrow, it's empty. I guess in distinguishing it from myelodysplastic syndrome, the white cells and the platelets that are there do not appear abnormal. You may have some funny-looking red cells, but the white cells and platelets are supposed to be normal appearing. And again, this is important when we try to look at these overlap syndromes, which I've been asked to talk about today. Chromosomal changes are very characteristic of myelodysplastic syndrome, but you can see it in about 10% of patients with typical aplastic anemia. And this is a bone marrow slide. The bone marrow is this in the middle of the actual cortical bone. And what you should see here is about 50, this white stuff is fat, and these very small pockets are the blood-producing cells. It should be about 50-50 at the age of 50. And if you go in either direction from 50, you can gain 10% for each decade you go up or down. So in other words, at 20 you should have about 80%. Keep hitting the wrong slide there. You should have about 80% of these cells and 20% fat. At the age of 80, you should have about 20% of these cells and 80% fat. So this person is either 100 or has aplastic anemia. What about MDS? Well, it's an abnormal clonal stem cell disorder. So stem cells are not typically reduced. They just are not producing healthy blood cells effectively. Unlike aplastic anemia, it has a very high propensity to transform into acute myelogenous leukemia. Probably occurs about 50% of the time. Unfortunately, the other 50% will often, I always tell people that this disease will always develop into AML if given enough time, but patients will often run into troubles from low blood counts from MDS and die from that, or they will have other health problems that, even though their MDS does not limit their life, those health problems do. Its incidence is uncertain, and the reason why its incidence is uncertain is that for decades it was not captured by the cancer databases in the world. The other problem is that frequently patients will have low blood counts and not have it investigated because they are have other health problems and the blood counts aren't that bad compared to their other health problems. So I think in many cases it goes undiagnosed. But the SEER, which is the cancer registry in the U.S., describes that its incidence, as best they can tell, is about 36 per million per year. So about 18 times that of severe aplastic anemia. But this is almost certainly an underestimate. So you'd expect that somewhere between 150 to 200 new cases of MDS will occur per year in BC. Its median age, again, as best we can tell, is at least 65, and I say as best we can tell because a lot of the older patients that have other health problems are in their 70s and 80s and just don't get included in this figure. So it's probably over 65. Only a small percentage of there's only a small percentage of young MDS patients. It's more common in men. Again, you can get congenital or what we call familial MDS, which is rare. Its etiology is really uncertain, although many of the things that cause aplastic anemia, drugs, chemicals, and radiation, are also known to cause MDS. And one of the problems in this disease, unlike aplastic anemia, is that there's a very long latency period between exposure to something and the development of the disease. And the best example which I give to patients is that those that were exposed to the atomic bomb explosions in Japan over 60 years ago still have an increased incidence of MDS, suggesting that radiation exposure over 60 years ago could increase your likelihood of getting MDS even now. So as you can imagine, it's very difficult to see a patient with MDS and go back through the decades of their life and figure out if they've had a specific exposure at a specific point in time. The presentation of MDS is also typically pancytopenia, so all of the blood counts are down. But unlike what I showed you, and I'll show you a picture of this, in MDS, the bone marrow is actually quite hyperactive, or it appears quite hyperactive, and that's because it's constipated. It's got a lot of abnormal blood cells in the bone marrow that just aren't being released. And the cells that are there appear very unusual looking. And again, you can see red cell abnormalities in aplastic anemia, but the white cells and platelet abnormalities, which I'll show you, are quite characteristic of MDS. And again, in this overlap syndrome talk, it is known that you can have underactive bone marrows that appear almost like aplastic anemia in about 20% of patients with MDS. So sometimes we see patients with pancytopenia and we just can't tell on the basis of their bone marrow whether this is aplastic anemia or MDS. Abnormal chromosomes are typical of MDS. When we see abnormal chromosomes in the bone marrow, we say, well, that's MDS. Although, as I showed in the previous slides, occasionally you can see that in aplastic anemia. About half of the patients you can identify chromosomal abnormalities in MDS. With the more sensitive techniques, which I am not going to talk about today, you can probably identify it in 80% of patients with MDS. And probably one of these days we'll get to the point where we know that 100% of MDS patients have abnormal genetics. It's an extraordinarily heterogeneous disease, so there's many, many different forms of it. And typically, it's also got a very heterogeneous prognosis. This is a different type of slide. This is called a bone marrow smear. I showed you a bone marrow biopsy for aplastic anemia. But what you should see is similar to what I described, and that is this is a particle of bone marrow with the cells coming off. This is what we actually look at. We can't see much if you look at that. But this is where we look at what the cells appear like when they start to spread out from this particle. And this particle should be, again, 50% fat, 50% blue, dark blue, at the age of 50. And this is a 70-year-old man whose bone marrow is completely packed. There's no fat in there at all. And he had MDS. This is the only slide I'm going to show you of abnormal appearing white cells, because even for physicians it would get a little tedious at times. But this is a normal infection-fighting cell. This is the neutrophil. The R's, of course, are red cells. These little P's are platelets. And this is a normal blood film. And this is a neutrophil, and these are the this is the nucleus, and it's sort of broken up into bits or segmented. And these granules are the infection-fighting component of a neutrophil, the sort of spotty appearance to the what we call cytoplasm. This is a woman because this is a bar body, and this is how this is the sort of screen that they do at the Olympics to see whether a person competing in the women's competition is actually a woman. This is an MDS slide, and what you see here is a neutrophil. It just looks very washed out. There's very little granulation, and that nice hypersegmented nucleus looks like an eyeglass. This is called a Pelger-Hewitt anomaly, and this is an abnormal white cell. And when this is seen in the peripheral blood by the pathologist, it's pretty easy to tell that this is MDS. And since I talked about chromosomal abnormalities, this is a look at what we call a metaphase analysis for a single individual. So I can tell that this is a man, there's an X chromosome and a Y chromosome, and then there are 22 other pairs of chromosome in a normal person. In this particular case, there was part of chromosome 5 and part of chromosome 1 that had exchanged. And actually, there are people in the world that spend their time doing this, looking at these chromosome analyses and trying to figure out whether there's something missing from one chromosome or whether it's been exchanged from one chromosome to another. So this one was an abnormal chromosome where one of these chromosome 1s put some material on chromosome 5. But in MDS, typically what you'll see is somebody with really bad chromosomes will be missing one of these chromosome 7s, so there'll only be one of them. So probably even I could tell if you lined up the chromosomes like this, and they spend a lot of time lining up these chromosomes like decorating your house at Christmas, and then figuring out what's changed. But MDS patients will often have one of the pair of chromosomes missing, like chromosome 7, and it may be much more than that. They might have 3 chromosome 8s, and so on. So, as I said, it's a very heterogeneous disease, and because of that, the prognosis is variable, and there are 3 things that we look at when we see a new patient with MDS. One is the number of cytopenias. In other words, do they just have an isolated anemia, a reduction in red cells, or are all 3 cell lines reduced? And that, well, if you have fewer cytopenias, then you have a better prognosis. Blast percentage. Blast is the most immature cell that we see in the bone marrow. Normal people have up to 4%, but depending on whether you have 5 to 10, 11 to 20, and so on, that will also contribute to prognosis. And the most important factor in deciding prognosis is the Marrow chromosome analysis. And there have been good studies that can now divide these chromosomes up into ones that we actually consider good, ones that we consider poor, and everything else goes in the middle and is called intermediate prognosis. And this is one graph that outlines a German group that determined what was good, what was intermediate, and what was poor in MDS, and they've got them color-coded here. But an example of one that's good prognosis is when part of your long arm of chromosome 5 is missing, what we call del5q. One that's considered poor is when you have complex abnormalities, in other words, many different changes in your chromosome analysis. And then the intermediate one, for instance, is, say somebody has 3 chromosome 8s, but everything else is normal. That's considered intermediate prognosis. So there are ways that we can quickly divide patients up into prognosis by their chromosome analysis. So you get a score for each of the three factors I showed you: the cytopenia number, the blast number, and the chromosome analysis. And when you get your score calculated by adding those three up, you end up as either a low, an intermediate 1, an intermediate 2, or a high. And the main reason that these are correlated with prognosis is they're very closely connected with the tendency of a patient to develop acute myelogenous leukemia. So high-risk patients have a median time until they develop acute leukemia of 0.2 years, or in other words, a few months. Whereas people who are low risk will have almost a decade median time until they develop acute leukemia. I just thought I'd quickly show you what sort of distribution of patients we typically see in MDS. So as you would expect, over half of the patients fall in the intermediate categories, either 1 or 2, 61%. About 10% will have high risk MDS at presentation, and then about a third will have low risk. But the vast majority, as you'd expect, are in intermediate categories. And the reason why I've gone into all of this is that treatment, the recommended treatment, depends very much upon your IPSS risk score at diagnosis. So we've now gotten to the point where we consider these two categories together, intermediate 1 and low risk, as low risk MDS. And these two categories, intermediate 2 and high risk, as high risk MDS. So we either have a low risk patient or a high risk patient when we first see them, and that will determine what treatment we recommend initially. For aplastic anemia, this is our treatment recommendation in British Columbia, and as you can see from the bottom, September 2001, it has not changed in a decade. Patients who present with aplastic anemia and are 30 years or less, we look for a sibling donor. That's what SD stands for. If they have a matched sibling, we recommend transplant. If they don't, or if they're beyond the age of 30, we recommend immunosuppressive therapy, which is a combination of ATG and cyclosporin. And only do transplants in situations where they don't respond, because, in fact, if they're in that category, they don't have a sibling donor. And that means that we would have to do an unrelated donor transplant. If they respond, if they respond and relapse, then we will retreat them with immunosuppression, and if they don't respond the second time around, then we do a transplant. So there's two main treatments for aplastic anemia: transplant and immunosuppressive therapy, and it's going to sound very much the same when I talk a little bit about MDS. And this is why we recommend transplants for young people. This is what we call a Kaplan-Meier survival curve. And for those of you who don't remember your statistics or never took it, then these curves actually show you how many people are alive and well at each point in time. And it's kind of a rough, bumpy curve because there are various people at various points in time on the curve. So what this allows you to do is predict how many people will be alive at 4 years, even if some of the patients are still relatively early after transplant. So that's what the Kaplan-Meier technique is. For HLA identical sibling transplants, if you're young, you have about an 80% chance of being alive and well 4 or 5 years after the transplant. Unrelated donor transplants, while successful in some patients, are not as successful as the sibling transplants. So the chances of being alive are 40 to 60% at 4 years. So because of that, we only use that when patients have failed to respond to immunosuppression. So in talking about the overlap syndromes, unfortunately, I've got to give a little bit of a background on what causes aplastic anemia. Lots of people ask me that question in my clinics, and I'll try my best to answer in the simplest way I can. In short, the lab research and the patient data suggests strongly that there is an abnormal immune response going on in the patient, with this immune response basically attacking the bone marrow and getting rid of stem cells. What triggers that abnormal immune response, as I say, is frequently unknown, but we know drugs can, chemicals, radiation, some infections, and pregnancy also seems to be something that can trigger an immune response. These are the markers that they have shown in the lab are increased in aplastic anemia patients. T lymphocytes and some of the chemicals that are produced by T lymphocytes, which I won't go into. Interestingly, it's only when this immune response reduces the number of stem cells to 1% or less that you actually begin to present to a doctor with symptoms of aplastic anemia. Because there was this abnormal immune response that was identified in laboratory research, it was decided that for patients that couldn't be transplanted, perhaps suppression of the immune system might improve their blood counts. And in the 1990s, at the NIH in Bethesda, Maryland, they developed this combination of ATG, or ATGAM, which is a horse anti-T cell product, cyclosporin, which is another anti-T cell drug, and steroids, which is a drug that's designed to make your face look chubby, but actually is not used so much for the fact that it improves counts like it did in Pam Weisart, but it's used to counteract the rather nasty allergic reactions you can get to ATGAM. What they found was quite successful for patients that didn't have donors, and that is that somewhere around 2/3 of patients would develop a response if their immune system was suppressed to the point that their blood counts would improve. So how does that relate to MDS, which we now know is an overlap syndrome with aplastic anemia? Well, what causes MDS? I think it's much more complex because it is a much more heterogeneous disease than aplastic anemia. As I said, about 20% of patients will have a bone marrow that looks quite a bit like aplastic anemia and is undercellular. And similar laboratory studies showed the same factors in some patients were abnormal, that T cells were ramped up and all their chemicals that they produce were increased. So that was one thing that suggested that there was an abnormal immune response going on in MDS too. The other thing that's interesting is that there were other autoimmune medical conditions that were much more common in MDS than they are in the general population. I've mentioned a couple here, which is systemic lupus erythematosus, or lupus, and rheumatoid arthritis. But there are a number of other autoimmune conditions that are much more common in MDS. 10% of aplastic anemia patients actually go on to develop MDS. So this was another suggestion that there was a close association between the two. And because of that, they started trying to treat MDS patients that weren't candidates for bone marrow transplants with immunosuppression. And they have found that while not as successful as in aplastic anemia, still about 1/3 of the so-called low-risk MDS patients respond to immunosuppression. It's not used virtually at all in high-risk MDS. It's the low-risk patients. And because of that, the concept of a group of overlap syndromes was developed. And then this group got together. So MDS is shown here in the middle, and aplastic anemia, while a separate condition, also has an overlap, as does a number of other disorders: acute myelogenous leukemia, myeloproliferative disorders, a disorder called large granular lymphocytosis, and of course PNH. There are also some closely related conditions which I'll only briefly touch on, and that is when the the bone marrow shows the absence of only one line of cells. So your red cells can be absent, but everything else looks normal, pure red cell aplasia. Your white cells can be absent, but everything else looks normal, agranulocytosis. And amegakaryocytic thrombocytopenia is when your platelet-forming cells are absent, but everything else looks normal. So let me talk a little bit about the overlap syndromes, PNH. This is not a congenital disorder. This is an acquired disorder. And what's abnormal in patients with PNH is that their red cell membrane, the surface of the red cell, is lacking a protein that anchors a number of things onto the red cell membrane. And because it's lacking those proteins on the membrane, it leads to the red cells being very prone to destruction in the circulation, especially when the blood becomes acidic, which it can become acidic at night, and that's how it got its name, nocturnal, that at night red cells were destroyed. When people got up in the morning, they would have episodes of bloody or tea-colored urine, suggesting that some of the red cells had hemolyzed or broken up overnight. Infections are another frequent trigger of a slightly acidic condition in your blood, leading to hemolysis and episodes of blood in the urine. It's not just a red cell abnormality. It is a abnormality that affects all of the blood cells, white cells and platelets. They also lack this anchor. And the platelets tend to clot. How that occurs is probably beyond the scope of this discussion, but it's one of the typical features of full-blown PNH, and that is that they are prone to clots, and the clots occur in very unusual spots. They don't get clots in their legs, like typical long plane flight clots. They get clots in and around their liver vessels. They can get clots in and around their brain vessels. So it's something that when you see that sort of a clot, PNH is something you should think of. Much like aplastic anemia and MDS, it's an overlap condition because often the blood cells are all down, so they present with pancytopenia. It's different from aplastic anemia in that the marrow is often normally active or perhaps slightly hyperactive, trying to respond to the lower counts. So it perhaps looks a little bit more like MDS. 25% of aplastic anemia patients will actually have a small number of PNH-type cells, what we call a PNH clone, when their blood is tested, and 20% of MDS patients will have PNH-type clones. Because the number of PNH cells is so low, people with aplastic anemia and MDS do not present with this typical get up in the morning, red urine sort of hemolytic MDS. PNH patients can actually go on to develop full-blown MDS, or they could actually develop aplastic anemia. So there's a very tight connection between these three conditions. And in fact, patients with aplastic anemia who are treated with immunosuppression, not with transplants, but with immunosuppression, about 10% of them over the first 10 years will go on to develop PNH, again enforcing the connection between these conditions. Large granular lymphocytosis is a disorder in which the lymphocytes that float in the blood and are present in the bone marrow have a very characteristic appearance, and they are large and granular. They not only infiltrate the blood and the bone marrow, but they sometimes infiltrate the liver and the spleen, so we see people with large livers and large spleens and a bone marrow that's infiltrated with these cells. But it often can be quite empty otherwise. So you can see patients you think have aplastic anemia, and when you check their bone marrow, there's nothing there except these large granular lymphocytes. Interestingly, similar to MDS, there's a very strong association with autoimmune conditions, especially rheumatoid arthritis. So a lot of people with LGL will have rheumatoid arthritis. They usually have a very low white blood cell count. That's their primary manifestations, but I have seen a number of patients where the white count's okay, it's just they have a dominant anemia. And the treatment, similar to aplastic anemia in some patients with MDS with autoimmune type disease, the treatment is immunosuppression, and it works very well. Pure red cell aplasia is probably the condition people think of when they hear aplastic anemia. So aplastic anemia really isn't just anemia. It's aplastic pancytopenia, but that's the name it got. Pure red cell aplasia is what you think of when you think of aplastic anemia. That is just a single reduction in red cells, single line form of aplastic anemia. There are no red cells in the bone marrow. Children develop this condition in an acute fashion, often due to a virus called parvovirus B19, and it tends to be self-resolving. You just have to support them through the initial reaction, and then they recover their red cells. But adults develop this in a much more chronic fashion. It's not as commonly associated with viruses and can occur from drugs. It can occur from other cancers, especially lymphatic type cancers. And it can occur with these autoimmune disorders. Again, another reason why this is in the overlap syndromes. Fortunately, it also responds very well to immunosuppressive drugs. So people who don't get transplanted often get immunosuppressive drugs with these overlap conditions. And the last overlap condition is chronic myeloproliferative disorders. There are a number of these, in short. There is what's called primary myelofibrosis, which is a scarring of the bone marrow. There's chronic myelomonocytic leukemia, which used to be considered an MDS, but now is more of a myeloproliferative disorder. And myeloproliferative means that the bone marrow is very, very active. Many of these types of disorders will present with low blood counts, and as I said, hyperactive bone marrows. Fibrosis is or scarring of the bone marrow is something that you can see in MDS. So there's a condition called MDS with fibrosis, which is not the same as primary myelofibrosis, again, highlighting the overlap that occurs between these conditions, and it often can be very tricky to decide whether a patient has myelofibrosis or they have MDS with fibrosis. And with that, I'll stop and certainly answer questions now or at the break, which I think we're coming up to. Yes?
Can you explain blast, please? We always hear about blast, but I don't think everybody knows, understand what blasts are.
Yeah. So when you look in the bone marrow, you'll see a spectrum of cells developing from the most immature form into the most mature form, which then is allowed to be released into the circulation. And the most immature form of a white cell that you see in the bone marrow is called a blast. You should have a few blasts in your bone marrow when you're healthy, but what tends to happen in these conditions is that the blast percentage tends to increase. And medicine has arbitrarily said that when you've got more than 5% blasts, but less than 20% blasts, then you're MDS. If you have more than 20% blasts, you're AML. And to show you how arbitrary it is, just a few years ago, it used to be 30% was the cutoff, and that people less than 30% would be called MDS. Well, then it was decided the 20 to 30% were more like AML, so they've been called AML. So blast percentage is just the blast is the most immature cell in the bone marrow. And the simplest way to describe it is that we'll often call it just the number of leukemia cells you have in your bone marrow. Although blasts in me aren't leukemic, often that's the easiest way to describe it to people. When you've got 5 to 19% of leukemia cells in your bone marrow, you're called MDS. Yeah. There are a number of scoring systems. The IPSS was the best scoring system to ever come along for MDS in 1997. Unfortunately, there are a number of flaws in the IPSS scoring system. It still recognizes that people with 20 to 29% blasts have MDS, even though the world has moved on to call those AML. And so far, I have not seen any clinical research studies that have used anything except the IPSS system to decide whether a patient is eligible to go on the study. So the world still uses IPSS, despite its flaws. With that in mind, there's been other scoring systems that have been developed, but this past year, the IPSS group got together again and are expected to release a new, updated, improved scoring system. So right now, I use the IPSS still, recognizing that there are flaws with it. Yes?
I was interested in your discussion about long latency periods and trying to determine what may be causes. And I'm thinking, in my instance, I'm a sarcoplastic MDS patient with a background in teaching woodworking. So I'm interested not only in the artificial things like paint thinners and all that kind of stuff, particularly xylene and some of the nasty ones, but also just the natural things like red cedar and other woods that some people are concerned about.
Yeah, I think that I always, although there is this long latency period and the data is not very thorough in what chemicals actually predispose to the development of MDS, I always take a very detailed history. Where did you grow up? Where did you live? Were you in a rural or urban environment? Did you get exposed to chemicals back in childhood? I see people, it seems that I see quite a few patients in my MDS clinic who have grown up on a farm. And, oh, yes, we used lots and lots of pesticides and insecticides, and we used to play in it, and I'm thinking, that couldn't have been good. But it's a very complex problem because this person that I'm seeing also has 5 or 6 siblings, none of whom have MDS. So why did they get MDS? And that's why it's such a difficult disorder to study, because it's a complex series of exposures. There's no question that there is a genetic predisposition. And the genetic predisposition is very complex in its own right. It probably involves the chance inheritance of multiple genes, not just one, but multiple genes that make you slightly more prone to MDS. But then you need to have the other exposures through life. You need to be exposed to pesticides in childhood, and then you need to be exposed to woodworking products in adulthood. And then maybe you need a virus that triggers the whole process at the age of 60. And your immune system has to fade out a little bit, which is probably why the incidence increases with age, that your immune system is not able to deal with the abnormal cells that we think develop in everybody's body. Yours is a very difficult question to answer, because I think that we still need more data, basic science data on what chemicals actually cause this condition. Although, just from what you're describing, I have little doubt that your exposure to the woodworking chemicals contributed in some way to the development of MDS. Yeah.
You mentioned about the cases in Asia, like there's 3 times as much cases in Asia than in North America with Aplastic Anemia. Why do you think it is?
Well, there's two main theories, and I suspect they're both right. One is that there is a genetic predisposition, that there is an ethnic predisposition to develop aplastic anemia. But the second, and probably equally important cause, is chemical exposure. That I'm not sure that the exposure of the general population to chemicals is as regulated in parts of Asia as it is in North America. So I suspect it's a combination of those two factors. Yeah.
Are you aware of any research that looks at multi-generational exposure? So, for example, exposure to chemicals that might cause something to function in the parent, who then pass along something to the child, and then the child will react and that with some kind of bone marrow failure?
Yeah, I'm not aware of exposures like that causing problems with the children. I guess one problem with that is that nature's way of dealing with that issue, if the child is being passed on significant abnormalities, is miscarriage, right? So I think that the child never comes to birth if there are some genetic abnormalities that are going to lead to a very poor outcome. So I think that's one problem that why that's not been well looked at. Yes.
What is the incidence of inherited aplastic anemia now? I know if there is a kind, is there some statistics on that?
Yeah, as I say, the two that are most commonly seen are Fanconi anemia and, again, another strangely named disorder. It should be Fanconi aplastic anemia. And dyskeratosis congenita. But the conditions are so rare. I think there is a described incidence, but aplastic anemia is rare, so it's extremely uncommon. Yeah.
We're starting to hear from people who have acquired MDS post
Yes.
chemotherapy radiation. I'm wondering, is their treatment plan different, and is their prognosis different, or is it completely dependent on yourself?
There isn't a good prognostic system for what we call therapy-related MDS. And that's simply because the original IPSS specifically excluded therapy-related cases. So you couldn't have therapy-related MDS to get into the IPSS that was developed. Having said that, I usually do classify the therapy-related MDS patients according to the IPSS, even though that's not how it was initially developed, simply because most of them do fall into a high-risk category. They have therapy-related cases, usually have very poor chromosome cases, very poor chromosome changes, and that makes them high risk. We have always considered therapy-related MDS high risk and try to do a transplant if at all possible. Yeah?
In connection with bone marrow transplant, the ability to be more successful has really increased 100-fold or more probably in the past 10 years. Do you see some new changes coming along in the horizon that is even going to make it more successful? And here in BC, is there a cutoff for a bone marrow transplant, either great aplastic anemia or myeloid?
I would, being a transplant patient, transplant doctor, I would say that there have been well-documented improvements in transplant outcomes. And I do think that transplant outcomes are going to continue to improve as we understand more and more about the biology of the diseases, and we improve the number of donors. I think one of the most exciting developments in transplantation is the use of cord blood as a source of transplants, because the the outcomes are surprisingly good and that there is no shortage of cord blood. There's lots of children being born. It's easy to store. And Canada is going to start a cord blood bank over the next few years. It's going to take a long time before it's up to speed with what the Europeans and the Americans have done already. And now I got so into that I forgot the second part of your question.
What is the cutoff?
Cutoff, right.
In the most general term.
Yeah, so we don't have an age cutoff, although I must say that usually we don't give serious consideration to people who are 70 or over. But having said that, by far the most important factor is what the patient's health is like otherwise. So we see 40-year-olds where we say there's no way we can do a transplant in this person because they already have heart disease, they already have diabetes and heart disease, and their performance status is so low. On the other hand, we see 65-year-olds that are in really good health. So we kind of threw out age as a cutoff. When I first started doing transplant, it was 45, then it was 50, then it was 55. And it's funny, it seemed to move at the same rate as the director's age. I think it was just a coincidence.